start it now. I think whoever's coming in.
Great. So we're going to go ahead and get started again, it's my pleasure to introduce the moderator and first speaker for this second session, which is on pediatric and family ethics. Lainey Ross is the moderator and first speaker. Dr. Ross is the Carolyn and Matthew Bucksbaum Professor of Clinical Medical Ethics here at the University of Chicago. She is a longtime associate director of the MacLean Center. I think that most of you know that Lainey is really a fantastic scholar. She's published 5 books and over 200 articles in peer-reviewed literature. In January, this January, after 28 years in Chicago, Lainey will become the inaugural chair of the Department of Health, Humanities, and Bioethics, and the director of the Paul M. Shivey, MD Center for Bioethics at the University of Rochester. It will be very sad for us to lose such a fantastic colleague of so many years, and someone who has really given so much to our the center and to our fellows for so many years, and we really will miss you, Lainey. We will be having a separate reception in Lainey's honor on November 30th. It's a Wednesday evening at the Quad Club, and so if you don't know about that, if you haven't received information, please let me know. But we will miss Lainey. Her talk this morning is Plus ça change, plus c'est la même chose, race and ethnicity in pediatric research. Thank you, Lainey.
Thank you. Thank you very much. And I want to thank Peter. I also want to thank Mark, and a special thanks to Kate Bucksbaum, who came, who over 20, I guess it's about 15 years ago, I was able to accept the first chair of the Carolyn and Matthew Bucksbaum Chair of Clinical Ethics, and it's been a wonderful experience. I just want to thank you for your support over all of these years. So I do have some conflicts of interest, none of which are related to this talk today. And so I have 2 goals today. My objectives are to examine whether and how race and ethnicity, as well as social determinants of health, are used in 3 pediatric journals. And then I want to consider how we make progress by acknowledging why and how we use race in research and how we can use it to promote health equity. And there are some low-hanging fruit. And so I just want to point out that my interest actually goes back to the late 1990s. I actually wrote a book called Children in Medical Research, Access versus Protection. And in that book, it actually starts in the mid-1990s when the NIH implemented a new policy that said you have to count the number of women as well as minorities who participate in all research studies. And that as they began to collect that data, it was clearly obvious that women and minorities were underrepresented in adult research. And so the question I asked was, are minorities underrepresented in pediatric research? Because I thought it might not be the case. And so that was what got me to start on this project. And so with the help of one medical student, Catherine Walsh, as well as 2 college students, Paul Ackerman and Michael Kelly, what we did was we collected data asking 3 questions. 1, are minoritized children over or underrepresented in research? And 2, were researchers considering the underlying social mechanisms? Sadly, when the NIH started their policy, the focus was just to collect race and ethnicity. And as we heard from Monica about intersectionality, but there are a lot of other social determinants of health. Race is not a biological factor, it's a social construct. And so shouldn't we be looking at all the other social constructs? And the answer is we really aren't. So these are 3 papers that came from that time. And I want to point out that data because what I'm going to show you is nothing's changed. And so our method was we took 3 of the main pediatric journals and we counted how many children were from different racial and ethnic groups and did they collect any social determinants of health. We excluded small studies, less than 8, because those aren't actually counted as research. They're just case studies. And we excluded all the studies that were over 10,000 that were using sort of Haynes data sets, because otherwise we'd be recounting and recounting the same children many, many times. And one of the first things you'll see is that we found 526 studies were examined and 192 met our criteria. Of those, what you'll see is that 167 involved child subjects. In pediatric journals, there'll often be studies of pediatricians, there'll be study of parents, there'll be studies of other partners. And so we just wanted to look at the studies that looked at children. And what we found was that 114 of them reported race and ethnicity. And as you can see, which were the groups that were frequently represented, I've put on this slide. And one of the things I did, wow, I'm really supposed to be able to see from this distance anyway. So what the results basically showed is that there are 2 columns that we're going to start in the first column. And is this a pointer? No, probably not. Okay, so in the first column, what you can see, what I've circled is what the census data are. And so what you can see is that white children were underrepresented in research, that they made up 54% of all the research participants, and yet they were 69% of the population in the year 2000. And what you can see is that Black children were overrepresented. They were at 26% when they only included 15% of the population. And all the other groups were also slightly underrepresented. So that Black children were actually overrepresented in clinical research in the pediatric literature. And so one of the things that we found was, although extensive documentation that minority adults are underrepresented, it wasn't the case in pediatrics. The Hispanics were underrepresented. And so one of the next studies that we were going to do was to look at the issue of translation. So were they being excluded in part because they couldn't meet the inclusion criteria of being able to speak English? Before we get to those studies, I just want to point out, we also then just looked at what was back then called social markers, and we asked if they included any social markers. And what we found, again, that 114, so 59% of all the studies did talk about the race ethnicity of the children. You'll notice that only less than half mentioned any other social determinant of health. And then when you combine, so you look at race, ethnicity, and social markers. So did they include both to try to look at, for example, Serena Williams, right, a wealthy Black woman, and the fact that she experienced so much discrimination in her healthcare. And what you'll see is that less than half of only half of the articles, 74 or 40% of the articles actually mentioned both. But when they mentioned both, only half of them tried to explain why it was even relevant. And so one of the questions we then went back to ask was, if you didn't think it was relevant, why did you collect it? So we documented, as I said, a social determinant, if any, were mentioned. And because of the variables, we really weren't able to get into much more detail about it. But less than 1 in 5 articles both reported and discussed social determinants and race ethnicity. So as I've been alluding to, so we did this follow-up study where we actually wrote to every single author of the papers, and we said to them, why did you include race, ethnicity? Why did you include social determinants of health? And the answer for the vast majority was, we included it because the NIH told us to. So even if it wasn't relative, so there would be a table in the results that gave you all the information you needed about race and ethnicity. NIH didn't require social determinants, so that didn't change. But then they didn't bother discussing it because it was either, one, not relevant to their research, or they really hadn't planned to do that type of analysis. So here was the study, and what you can see is the first column was the original data I just showed you from 99-2000. This was a study from 2002-2003, and basically the data are exactly the same. Nothing had changed. The fact is that there was an overrepresentation of Black children. And all the others stayed the same, being underrepresented. And so then what we did was we also asked them, for example, how did you collect race ethnicity data? And what you could see when they responded, and 157 responded, and 93 said self-report, which is something in 2022 we would insist upon. But you'll also notice that 28 of the studies, the researchers said, well, I just looked at the participants and made a race ethnicity classification. But we then also looked at the language options and whether translation was available. And one of the first things to note is that 82% of articles didn't state whether there was a language proficiency. That doesn't mean it wasn't. 22 articles, actually, 9.6% said English was an inclusion criteria, that if you didn't speak English, we didn't enroll you. From that survey, we learned that one included Spanish consent, but the child needed to speak English. In 17 of the studies, they stated that translation was available. One study, in fact, was done solely in Spanish. 2 studies were observational, so language was not relevant, although they still needed parental permission. 1 study with Spanish consent forms, as I've mentioned. And so when you look at it, what you come down to is to realize that only about a quarter of all the studies translated. And particularly in the pediatric community, where we do have a lot of first-generation children, the lack of translation would mean that I'm not surprised to find that Hispanic children are being underrepresented in pediatric research. And in fact, when we did studies that looked at studies that included translation, those studies, we found there was at least equal, if not overrepresentation of children from Hispanic families. So after the murder, the senseless murder of George Floyd, I sort of looked at the students sitting in my office that day and I said, I wonder if anything's changed. But I actually decided to wait a while, because from the time an article is accepted until the time an article gets published, it's like a 6-month delay. So I said, if they're going to do anything, let's at least give everyone the benefit of a doubt. What I should say, there was one other change from when we first started collecting the data, is that some of the pediatric societies started writing statements about the issues about race and ethnicity in pediatric research. So in June 2000, the American Academy of Pediatrics, their Committee on Pediatric Research, stated that it's no longer sufficient to use race ethnicity categories as an explanation, and argued that pediatric researchers should collect data relevant to the underlying social mechanisms. So we're expecting now we're going to see a much greater, not just race and ethnicity, but also social determinants of health. And in February of 2001, the Archives of Pediatric and Adolescent Medicine, which is now known as JAMA Peds, they wrote something similar. Researchers should not use race ethnicity as explanatory variables, but should measure the underlying constructs directly. They did acknowledge the importance of using race ethnicity to target attention and resources to overcome health disparities. And so did any of these type of statements change research or practice? So we collected the data again from 21 for 6 months this time. We again had the same exclusion and inclusion criteria, and except for updating the language from social markers to social determinants of health, basically the methodology was exactly the same. And I did this with 2 other students. Wadsworth is now a pediatric resident, and Luria and Ayush has just started medical school at the University of Minnesota. And so here we have 385 original articles were published, and 68, so 17% of the articles were excluded. So we're left with 317 original articles, and this just gave you a little bit more flair of the different type of articles and how many were from each of the journals. Here, what you see again is we looked to see how did they collect this data. And so the good news is that there was a really, that very few of the studies, only 3 had researchers reporting race ethnicity. If it weren't self-reported, it was taken from the EMR. Of course, how the EMR got the records, we don't know. This, rather than just summing it up, I thought I would just show you what they did in collecting race and ethnicity. Because if you want to compare between studies, it would be nice if you had the same terms. So what does it mean to be a white candidate? That's the different categories. And if you were a Black candidate, that's the number of categories. There's some favorites as you look through that list. Then we looked at social determinants of health. And again, there was no standardization. So one of the things we did was we used the CDC, their categorizations of the 5 different classes of what counts as a social determinant of health. There is this score called the Hollingshead, which actually crosses 2 of those categories. And so we had a separate classification for that. And then again, we looked at, you reported it, did you try to use it as explanatory? And again, what you see is the loss. So all the articles, we start with 61% mention race, and by the time we're looking at discussion, it's down to 13%. We distinguish between US and international just to see Just out of curiosity, although it's become very interesting to us, because one of the studies we're now working on is if you publish in a international journal, are you going to report? And if you're reporting, are you going to disclose? But that's for next year. This year, we'll still look at, did they tell us about the social determinants of health? And here, less than half of the articles mentioned social determinants of health. And when you look at whether they interpret it, we're down to 6.6%. So really sad. So we're doing better about how we collect race ethnicity data. We've moved away from the doctors sort of looking across the room and allowing for self-identification. But the gap between reporting race ethnicity and discussing it has not changed. In fact, the gap between reporting social determinants of health and discussing social determinants of health has not changed. And in fact, the gap between contextualizing race ethnicity by reporting both has not changed. I don't want to be misunderstood. I'm not suggesting we stop reporting race ethnicity. I think that Ioannidis' quote is really, really powerful and important. If for no other reason than the further exposition of health inequities and systemic racism, the use of race should for now persist in medical research, but the imperfectness of race as a tool is problematic. However, I would argue to identify and combat the systemic racism and oppression that have been woven into the fabric of practicing medicine in the United States and around the globe, journal editors should require researchers to be more intentional in their collection, reporting and analysis of race ethnicity, and to interpret its significance when appropriate in the context of diverse social determinants of health, something that is clearly not being done in the pediatric literature. So our next steps is that I think we need a national body to insist upon the harmonization of how race and ethnicity are collected and how they're reported. We need a national body to identify which social determinants of health we're actually going to collect. And again, they need to be measured and collected, and they need to be determined. There needs to be harmonization. We need a broad and sustained community response to address the underlying health inequities and systemic racism that make the use of recording race in medical research so necessary. And finally, we need to come to consensus on when and why to collect which data. And I'm just going to keep emphasizing that we should have reasons for collecting the data. So our next step, as I mentioned, we are looking in European journals to see what they're doing about race, ethnicity, as well as social determinants of health. And I'm again working with Ayush and Wadsworth, and we're looking at the same time frame as our most recent project to see what's similar and what's different, and do American researchers publishing in European journals actually change their practices where it might not be required, and things of that sort. So I want to acknowledge the students who worked with me over the years, and thank you very much. So Peter, since you're sitting there, do I have time for questions? Yes. Okay. Any questions?
Yep. Joel Howell, University of Michigan. Given the contingent nature and the intersectionality and the complexity of that which you are studying, I would be fascinated if we could see a combination of your data along with the similar data for the investigators. Because if it matters, if race and ethnicity and social constructs matter for the patients, they surely matter as well for the people who are doing the research.
Yeah, so the studies that I've been doing in 21, 22 are exempt, so we've had absolutely no contact with the researchers. The one time we did contact the researchers, we did not ask those questions, to be very honest, but we did ask them about, whether they translated and things of that sort. But it would require us to actually ask, and it would be interesting to see what type of response you would get. I don't know. I mean, but again, you would have to compare it though. That would be hard. Then you would be comparing it to AAMC type data of who are MDs and PhDs. So it might not look at all like the patient population. The question is, are they over or underrepresented within those of us who go into medicine, academic medicine, and things of that sort?
No, it would absolutely not be representative of the patients, but nonetheless, does it matter who you are as a researcher in terms of your race and ethnicity and socioeconomic positioning and with all of the complexity?
Yeah, so the only thing I'd say about that though also is that that science is team, it's a team. And so one of the things you're sort of asking me is, let's look at the PIs, and that's an important factor, but it'd also be the whole team that we would really
look at the whole team
the
anyway.
data.
It'd be interesting.
Yeah. Thank you.
I think I might be next. Hi, Lainey. Fantastic talk. I wanted to ask about the use of self-identification of race versus race as assigned by the healthcare provider. It seems to me if we're worried about interpersonal racism and the way people are applying a social construct to someone and treating them differently, maybe it's better to know what the healthcare provider thinks the person's race is rather than what they self-identify. I don't know. I mean, it's curious on your thoughts on that tension.
I think that individuals should be able to determine what they perceive their race and ethnicity is. And I think that's actually really important, not just for research, but even in the clinical charts. And if you as a provider are curious about why they chose that, then maybe that's a conversation to have. I'm going to bring up some British data because it's actually fascinating. The British were trying to figure out back in 1990s, they wanted to do to screen for sickle cell disease, but they had a very small number of people who they thought would be at risk for sickle cell disease. Sickle cell disease, as we know, really goes along the equator. And so what they tried to do was collect race ethnicity data. And no matter how they tried to put people in boxes, when they asked the participants themselves, it didn't work. So they had, for example, one example was they offered Afro-Caribbean and British white. And people said, I'm British. I might have ancestry of Afro-Caribbean, but I'm British. So I circled British white. And because they weren't being given the options that they felt identified themselves. So I think the idea that you or I should be able to identify someone is really problematic. Anyway, the end result was they couldn't, no matter how many times they tried to make a form that worked, they couldn't. And so what they did was they made universal screening, which was the right answer. They came at it from the wrong reason, but they got to the right answer.
Yeah, and just I think Monica has her hand up next. To clarify, I was certainly not saying that it's like right for healthcare providers to assign racial identities to people, but if you're worried about if the purpose of the study is to study racism, isn't their classification of a participant kind of maybe perhaps the relevant thing that I don't know.
So what I would say is that this idea of self-identified race versus socially assigned race has been studied, and it does have impact. And it's part of actually the CDC's optional module that Kamara Jones created called Reactions to Race. And so we know that for people where there's discordance, where they look one way or identify one way, but people think they're white, for example, their health is better than if they perhaps are like me, where I'm Black and I look Black. And so I think there is something to be said, but I think what is probably more consistent is to ask that person, what is your socially assigned race? And what is your self-identified race? And then that way, but anyway, that's how it's been done, sort of.
So collect data on how they're being identified.
So
And
as we
both.
discussed that, do we know how race is assigned in our EMR?
I'm hoping it's self-identified. I mean, the standard is self-identified race.
My kids are.
Mhm.
Okay, so there is some self-identification or family. Oh, ask the nurse, not the parents. Well, so that's the thing that I'm really trying to
Right, avoid.
avoid. Exactly.
I've got a PSR say to me, you're not Hispanic. When I check in, you're not Hispanic.
Okay, and so for those on Zoom who aren't hearing, we're discussing how it works here at the University of Chicago, and Dr. Lindo has been asked whether she is Hispanic or not. Rick. It is. So it's a Kahneman and Tversky with thinking slow and fast, in the sense of thalassemia is more common in one group, but that doesn't mean it doesn't exist in all groups. There's actually a great YouTube video, which is that you should all watch, which is done by a medical student who said, in order to pass the national boards, I had to become a racist. And the reason he said that was in order to the shorthands. So when you heard an immigrant family, you were supposed to think maybe not immunized. And when you heard a Black family, you were supposed to think sickle cell and things like that. And so the problem with the shorthands of using race, ethnicity in that first sentence is that it may be right statistically, but that's not accounting for the individual person. I do think we should eliminate it. I don't think that we should eliminate it from the medical record. I think it's important, but that we always begin that, even when for many conditions it may not be relevant. I think it's a bad way to start. It may come up in another part of the history. We're done. All right. Thank you very much. So it's now my pleasure to introduce Kelly Michelson, who will be talking about using artificial intelligence to predict mortality in the pediatric intensive care unit, promises and pitfalls. Kelly, former MacLean Fellow, is a professor of pediatrics. She is the Julia and David Uline Professor of Bioethics and Medical Humanities, Director of the Center for Bioethics and Medical Humanities, and Chief Ethics Officer for the Institute for Augmented Intelligence in Medicine, Northwestern University Feinberg School of Medicine. She's an attending physician at Lurie Children's in the Division of Pediatric Critical Care. Kelly?
Thank you so much, Lainey. I wish I could be with you guys. Can you hear me okay over there? Okay. I understand I'm the first virtual speaker, so thank you for letting me speak virtually. I think you all are probably glad I'm virtual. As you will hear, I may cough. I'm getting over something, so apologies for that. I'm really grateful to have the opportunity to talk with you all, so thank you. And I just want to take a quick moment to give my heartfelt thanks to all the veterans and military personnel in service to our country. We stand together better because of you. I have a couple of disclosures around grant funding. In terms of my objectives for the next few minutes, I was going to touch on some technical considerations, basically hoping that you'll understand how technical issues can lead to ethical challenges for AI and ML predictors of mortality. And I should say that I'm going to use AI and artificial intelligence and machine learning somewhat interchangeably, which is not technically correct, but that is what I'm doing for the purpose of this talk. I'm going to describe some how AI and ML predictors of mortality can impact clinical care and explain some potential organizational and legal considerations. So just to kind of get started, I really want to acknowledge that there are multiple ways in which AI and artificial intelligence and machine learning are moving their way into healthcare these days. We are seeing people use AI for the purpose of diagnosis. There's a lot of work in the area, for example, of breast cancer diagnosis using radiology. Almost everyone or many people in their day-to-day lives are using AI for monitoring things like physiology and heart rate and identifying arrhythmias. AI can be used to identify appropriate treatment modalities. It can identify people who are at risk, who have a particular disease process, prognosis as well. AI can even be used to help people write papers in general and also in the medical field, and we're seeing that. There's been material published about using AI to actually make recommendations for ethics consults in the clinical setting. We see it in education and even like how we as individuals keep ourselves educated with the sort of onslaught of so much information and literature. AI can be helpful in kind of focusing what you pull and learn and where you take draw your attention, as well as therapy. And we're seeing it a lot, for example, in the space of psychotherapy and using bots. And those are just a few examples. But we're going to kind of focus on AI or machine learning for the purpose of prognosis and specifically predicting death. And I'm focusing on the pediatric intensive care unit. That's where my clinical practice is. So why would we even want to think about doing this? There's a lot of reasons, including that these kind of predictions can help us. I'm just noticing, okay, a chat about hearing me. So if you can't hear me, tell me. I'm going to keep going. How we can measure care quality. So if, for example, we know that for a particular population, most children in certain circumstances would survive, and a hospital is seeing that's not happening, then we would want to identify that and consider how we can make improvements to care. It's used in research to think about case mix, identify specific populations, adjust for severity of illness. It can impact management plans. It can help with how we talk to our patients about goals for their care, and whether we even choose certain therapies. And I'll touch on that a little bit later. And then also considerations around donation after circulatory death and thinking about, will patients actually survive, or will they die in the allocated time? Currently, there are 3 sort of mainstays for predicting mortality in the PICU, and they are listed here. As you'll see, there are a lot of other tools that are emerging, but I would say for the last decade or so, these have been kind of the mainstays. And what are the limits to what we currently have? Well, first of all, most of the scoring systems that we have, which these tools typically identify physiologic markers that you can pull from the medical record, put them in a calculator, and then you get a risk prediction of mortality. Most of them rely on admission data. They tend to be less accurate for prolonged ICU admissions, and they're mostly validated for group risk determination, which is not necessarily going to be applicable to the individual patient. So I'm going to kind of present some of the ethical challenges associated with using machine learning in this way to predict mortality. But I guess it's important to ask if we really need to even be having this conversation. And I would argue that there's a lot going on in this space that make it hugely important. As a few examples, this is a recently published paper looking at predicting mortality in the PICU using neural network modeling. This is a paper describing using machine learning to predict cardiac death within an hour after a terminal extubation. And again, these authors were thinking about how can we make sure that, or how can we have a better knowledge about whether or not someone is going to die in that time period that that many protocols require for families to donate organs after circulatory death. And we've seen machine learning used to predict death for coronavirus, and we know that some of these prediction models have been proposed as options when considering scarce resource allocation. And I'm not going to go into that. I think there's a whole panel related or touching on that. And even thinking about predicting mortality in pediatric war zone casualties. So from my perspective, this is happening. The train is like on the tracks, leaving the station. And I think as ethicists and healthcare providers, it's our responsibility and obligation to kind of catch up. So thinking about some of the technical considerations, and I have to admit, I'm not like, I don't create AI or machine learning algorithms. So this sort of schematic is meant to be an overly simplified view of how this process works for the purpose of our discussion. And essentially, most of these models are created from existing data. So in this case, maybe you have data from, PICUs across the country for the last 5 years or something, and you would take a piece of that data as the sort of training data set and identify those patients that died, those patients that survived, and the machine learning algorithm would be created based on those outcomes using that data. And then you would take that algorithm and you would pull another set of data that would be used to tune or evaluate whether that algorithm is functioning well. And that would be sort of become the algorithm that you could then test and look at performance and whether or not it's functioning properly. So that just gives you a general sense for how this process is happening. So what are some of the benefits from the technical side of things? First of all, the opportunity for efficiency here is enormous. To be able to have these data pulled automatically, churn out the results, and even to have this happening on an ongoing basis. There's huge opportunity for enhancing accuracy as more data is included. So sometimes these models and algorithms can be created in a way that they sort of iterate and improve as additional data are added. They provide real-time information, and they can also in some ways mitigate provider systematic bias. So as a clinician, if I look at one of my patients and I'm theoretically looking at the clinical situation and I come to some perspective about what I think their mortality risk is, I may be knowingly or unknowingly influenced by biases that don't actually relate to what's going to impact their mortality. Theoretically, these algorithms would potentially not include those biases. But I think it's really important to know what the machine is actually predicting. And to explain the importance of this, I'm going to use an example. So in this case, there were investigators interested in identifying melanomas from images of moles. And they had images, they used those existing data to create an algorithm and tested the algorithm on a new data set. This is the process that we kind of just talked about. And they found that it was incredibly accurate. But what they went on to realize when they looked more carefully at what it was the algorithm was identifying in these images, what they found was that when a patient came in who had a concerning mole, that the clinician would often include in the image some kind of scaler, like a measurement device, as you can see here. And so when the algorithm was figuring out whether something was melanoma or not, it was actually triggering on this scaler present in the image, as opposed to the image of the mole itself. So you can see that it's really important to know what exactly the algorithm is using to make these determinations. And many people will call this the black box dilemma, where, I've presented this process in a very kind of high level, simplistic way. In reality, they're far more complex. And in many cases, it's impossible or nearly impossible to actually figure out what exactly the algorithm is using to make the determinations and come up with an output. And this can have huge impact for people on sort of issues around transparency and trust. And we'll kind of circle back to that in a little bit. And then it's really important to remember how important the data is. Here I wrote the devil's in the data. So really, not surprisingly, predictions are only as good as the data that we're using to create these models. So what if the data about death is not accurate? And for example, thinking about where I work in the pediatric intensive care unit, we certainly have a lot of kids who, based on goals of care decisions, might leave the intensive care unit alive and go home, maybe on hospice, and die shortly after. Well, unless you have a plan in advance to follow those kids, you would not characterize them as a patient who died. Similarly, there's plenty of patients who go home and die after they leave the intensive care unit without being in hospice or palliative care, and you would miss those. There's also the concern about inaccuracies in our data, and that sometimes those inaccuracies are reflective of biases. And one example to think about this is pain management for patients who come into the hospital. There are data that show that people who are Black or perceived by clinicians as Black often get less pain control for the same level of pain. And so that information kind of gets baked into the data and can impact what happens with these algorithms. And sometimes those biases fall in that sort of individual way, or from the clinician. And sometimes those biases also come from much larger systemic issues. And to exemplify that, this is an example of a study where they were trying to identify people who were at high risk of serious illness. And their goal was to figure out who was likely to get very sick so that they could connect those people with additional resources for support. So they created an algorithm to identify this, and they found it to be accurate of predicting who would get seriously ill. But what they didn't realize is that one of the key drivers of figuring out who was getting seriously ill was related to cost measures. And they realized that for segments of the population, in this case, again, individuals who identify as Black, that population, for whatever reason, intentionally, unintentionally, systematic issues, there are certainly a plethora of reasons one can imagine, weren't utilizing the healthcare system in the same way as other populations. And as a result, they were utilizing it less. Therefore, their cost data was smaller. So the end result was that you would have a person who was Black who would be at the same level of serious illness as a person who was white and was not triggered by this system as being at high risk for serious illness. Then that person would lose out on these additional support resources, which then further kind of feeds into the project problem. And so one of the challenges in relying on data is that you kind of end up in this loop where there are social inequalities that end up baked into the data that lead to skewed representation, which then is reflected in the model. And then you get skewed errors, which are further impacted, further reflected in predictions and decisions, and leads then to unfair treatments or outcomes for people. This then just becomes sort of a circular problem. So what are some of the clinical considerations? Again, there definitely are potential for benefit, and I went through some of those already. For those predicted to die, one could imagine a more aggressive approach to comfort care, including sedation and pain control. And while I know that many would argue that we ought to be able to do adequate sedation and pain control regardless, I think there are certainly, as a clinician, I feel there are certain circumstances in which people tend to be more aggressive if they kind of have knowledge of where things are going or if there's care limitations. And even for those predicted to live, one can imagine that this would really support the use of high risk and intensive resources. It could also support the use of those therapies that may have really high side effect profiles, and potentially even decrease the decision-making burden for families. So if we go to a family and say, look, this is a difficult situation and you have two bad decisions to choose from, and we have no clue what's going to happen, that might be more burdensome to families than if we say we have two challenging or bad decisions to choose from. And we think it's very highly likely that regardless of those choices, this is what's going to happen. Or at least if we, yeah, I'll let that sit. But some clinical challenges. I think that one of the things is that it can limit advancement of medical knowledge. So I sort of mentioned that these algorithms can sort of grow as the data grows, but if we use these mortality prediction models to impact how we care for a patient, this could also become sort of a self-fulfilling prophecy, and that our management could sort of reinforce these outcomes, which could potentially limit the expansion of knowledge and development of healthcare and innovation. And I think it also really potentially takes the family somewhat out of the clinical decision-making process. And I think this is particularly true for those situations when we can't be really clear about what it is that the model is using to come up with the determination. And without that information, without that transparency, I think trust can be highly impacted and kind of fall into balance. There are some organizational and legal considerations that I think are also worth mentioning, including whether or not.
Kelly, 2 minutes.
Thank you. I was like, I see Lainey up there. Okay, thank you. I think we're good here. You know, if we had these prediction models and we implemented them, could we actually decrease costs because we would maybe make changes in the care of those patients who are going to die sooner? Can the data actually be used as a source of revenue? And how should patients and families know about how AI is used? Which in fact, it's already used now. And to what extent should they be aware of that? And there's a lot of conversation too about what are the protections for patients' data? And this really kind of focuses on privacy and confidentiality. We know there have been lawsuits against healthcare systems for sharing data. And so this is kind of one of the sort of mixed motivations for healthcare systems and leads to a lot of legal challenges. So one of the legal issues is just sort of thinking about who's liable when AI or machine learning prediction models are implemented. So if the AI says the patient's going to survive and the patient doesn't, and you know do everything that it says and the patient doesn't survive, who ends up being liable for these sorts of things? And this, I think, is very much a moving space. I think in general, right now, the law protects clinicians who follow standard of care, but really figuring out when utilization of AI becomes part of standard of care is not always a clear line. And what about the data sharing? I already mentioned this. We know that HIPAA doesn't protect data across all business entities. There are certainly states adopting data protection laws to help to take this into consideration, but that is very much a moving area. So what should we do now? Well, I have to admit, I don't have all the answers, and mostly I'm really just presenting the problem. But what I can say for sure is that we definitely need to get on the train. This is happening. We as ethicists, healthcare providers, clinicians, people, human beings need to be on the train and thinking about this and the impact that it has on our culture, our society. I think some of the major issues to address include, as I've alluded to, informed consent, safety and transparency, privacy, fairness and bias. And I wanted to bring this in just at the end of the conversation to acknowledge the role of clinicians and human beings as we start to bring machines into healthcare. This was in the field of radiology, and it was a study asking people about patients, how they might view AI and reporting radiology images. And what for me was interesting is that when asked about discussing the results, people really wanted human beings involved. They wanted that personal contact. And I think that's really important for us to understand. I really like this quote from that also relates to radiology, but could be really anybody, that AI won't replace radiologists, but radiologists who use AI will replace radiologists who don't, which at least I think reflects our current situation, which is to say there are a huge number of benefits to AI and machine learning that can help us take better care of our patients. And that doesn't mean, that can't mean, at least right now, and I would argue going forward in the future as well, that we take human beings out of the loop. So people talk about the doctor-patient relationship and going from sort of parentalism to shared to now what I see as the future as incorporating technology. And I see you there, Lainey. And I just wanted to acknowledge my colleagues, Craig Klugeman, Abel Coe, and Sarah Gerke, who have really been instrumental in my thoughts in this space and area. And I welcome any comments or questions.
So I want to thank you, Kelly. I fear we're not going to be able to take any questions because we went a little bit over. So I am going to invite Sarah Hohen to come up. She'll be our next speaker. Sarah is the Chief Medical Officer of La Rabida Hospital and Clinical Associate at the University of Chicago. Before Sarah moved over to La Rabida less than a year ago, she was a faculty member here in the Department of Pediatric Critical Care, an assistant program director of our pediatric residency, and a member of the MacLean Center for Clinical Medical Ethics, and ran our ethics case consult service. Thank you very much.
Okay, I'm going to start my timer. We are cognizant of the fact there's 2 talks between now and lunch, so we want to make sure everybody gets there. I have no financial disclosures or conflicts of interest, but what I have learned giving this talk a few other places is that sometimes it makes people uncomfortable. So I just sort of let it out there. I don't have answers to anything, but I'm going to generate a lot of questions and hopefully give you some things to think about. So what is La Rabida? What do I do all day long? Question many people have. So it's an acute care hospital focused on children with complex medical needs. So essentially we have a lot of kids that are technology dependent, on ventilators, have gastrostomy tubes. Currently we have 35 beds. We're doing a big construction project, so we're going to go to 39 beds next summer. And then in terms of the outpatient clinic building, our big areas are sickle cell disease, diabetes, pulmonary, and technology dependent clinic. And yes, we do have consent for all of the pictures that are included in this presentation. So what am I going to talk about? Anything with pediatric ethics comes down to what are the limits of parental decision-making. I'm going to talk very specifically about the issues of health equity when we're discharge planning. So you've gotten out of the NICU, you've made all your life goals, we've learned how to care for you, and then we're going to try and get you home. And what are some of the barriers that come up when we try and get people home? And then we'll see if we have time. But if we do, then I'm also going to talk about the religious exemption to brain death and how this factors into complex discharge planning, because there actually is a connection between brain death and discharge planning as well. So pediatric ethics, everybody knows that you want to do what's best. So beneficence is always at the forefront. And we do think that the parents always have their child's best interests at heart, with the exception of abuse and neglect. Kids with complex medical needs are different because we're essentially teaching families to reproduce in ICU at home. And so what we're asking of families is a very high level of care at home, where we want them to be the doctor on call, we want them to be the respiratory therapist, we want them to be the nurse, and we want them to be the pharmacist and draw up all the medications. So we're asking them to take on a lot of roles while simultaneously saying, oh, don't worry, you got this. It takes 100 of us to do it in a hospital, but you can do it at home and you'll be fine. So this is our big dilemma all day, every day. Should I stay or should I go? And so this comes up. There's a lot of different processes in place to get these kids home, and it's under the DSCC waiver. We know that there's nursing shortages across the world, and we know there's nursing shortages in Chicago, well, that also impacts home nursing shortages. So many, many years ago, when I was at the Children's Seashore House, nobody was allowed to leave the hospital unless you had 2 weeks, 14 days of 24/7 shift nursing. And that was our old standard, and that's what we looked at. Nowadays, if you have 3 12-hour shifts in a span of 7 days, we're like, look at that, you won the lottery, let's go. So the expectations for what are provided at home are very different. All the policies are still the same, but what you can get realistically in 2022 is very different than what you can get in, 20-something years ago. There are unique programs, especially in Illinois, where people can be paid to care for their child. This comes up a lot when we have older siblings and things like that, where someone turns 18, 19, and they can be the paid caregiver for their sibling. So that's sort of the background I want you to have as we go through some different scenarios. So like we said, the goal is to train caregivers. So in the perfect world, that's what everybody has. I'm a single mom. So does that mean I'm not allowed to take my children home? Like, what are you going to do about that? So we say 2 trained caregivers. Sometimes we don't have 2 trained caregivers. Sometimes there's a grandmother. Sometimes there's an older child. Sometimes there's not. So this is where we do give families the autonomy to say, what do you feel comfortable with? So we do let families go home with 1 trained caregiver, and we make decisions based on what are their goals and what are their objectives and how can we get them home safely. So I'm going to go through a couple scenarios that are all pretty common and could be replicated any place in the country. So a 16-year-old with muscular dystrophy, single mom, has a progressive disorder, is going to eventually die from her disorder, is on a ventilator, a feeding tube, totally dependent for care. Her mom says, I want to take her home. We have 41% of the hours in the week staffed, which, remember, we try to get people moving if we have 3 shifts in a whole week. So this is a lot. And mom says, oh, I'm not ready. I'm not ready. I'm not ready. Well, people are saying, well, when are you not ready? Is there a time that you can say this? How many times can we have these sort of false starts? And for people who say, I'm never comfortable going home, that's fine. There's plenty of long-term care facilities we can send kids to be in long-term. We are still an acute care facility, so we're not a long-term facility. But there's questions that come up about, well, it's been 3 months, maybe it's been 3 years. Where are we going to draw the line? And do we ever draw the line? So the second one, a 3-year-old with skeletal dysplasia, he's gotten a little bit better. So he's on the ventilator at night. He has 2 family members. He has a million aunts and uncles. He has a church community filled with healthcare providers. They have lots of, people around, people trained. They have 8 shifts per week, which is the same 41% of the hours that our other patient has. And this time the family cancels discharge repeatedly because they haven't quite finished their home renovations, which, can be challenging if you do home renovations. But just think about that in terms of what are some of the different things that we're asking families to get ready to do, and when do we give them different choices. So then this is a child who has hypoxic ischemic encephalopathy, is on room air, bolus G-tube feeds, and doesn't need a ton of technology. And mom's like, I'm going to take him home. We're like, that's wonderful. We're so happy for you. When works for you? She's like, well, I think when I finish graduate school. I'm like, okay, that sounds good. And that's like a 3-year program. So we're like, well, that's probably not the best answer. But what are we going to do? And she's like, well, I want to wait till I buy a house because I could go to my mom's house, but my mom's house has a lot of smokers and my baby's high risk. So I don't want that. So is it ever appropriate to call DCFS? Like, when does it ever become child abandonment to say, I'm not going to take my child home? And in the interest of time, we're going to skip the poll. But the other time where we interact with DCFS is when people do the opposite. So they have a total refusal of nursing. And so these are cases when you have a child who has static encephalopathy, comes in with multiple ulcers, all these different things. But then even if DCFS takes custody and goes to a judge, sometimes a judge says, well, I'm not going to remove her from the home because, this family loves her. She's not going to live very long, and I want her to be with the people who love her. But this is complicated because as mandated reporters, as all of us practicing in pediatrics are, we're obligated by law to report any suspicion of concern or harm. We do know that if you have a newborn and you want to give up your newborn, you can take your newborn to the fire station, but we don't have a fire station equivalent for children with complex medical needs. You could come drop your child off in the ER, and yes, they will be safely cared for and they will be admitted, but people are going to call the telephone and call DCFS and say they abandoned their child to me. And so there is going to be repercussions, and we don't have the same safeguards in place for newborns as we do for technology-dependent children. So we've heard a lot today about health inequities, and we know that there's a huge difference, right? If you're taking your child home to your, humongous house with 18 different people versus to a 2-bedroom apartment where there's 12 people staying there. Everyone's in one room, and then you have to have a separate space for the technology-dependent child. There's regulations for home nursing. You have to have a separate chair, you have to have a place to sit, and you have to have a dedicated environment. So this is one of my favorite babies. She was a baby with congenital heart disease because of concurrent care, which passed under the Obama era. She was able to have hospice and technology-dependent nursing. So she could be on her ventilator and also get hospice nurses. And she called me one summer day. It was really hot. She's like, I don't know what to do. It's just so hot in here. I'm like, I know, I got you, girlfriend, headed over. So I, go in my basement, get my extra air conditioner, go over to her house. And no, I was also her hospice doctor, so I didn't violate any boundaries there. But I go to her house, I help her, we set up this air conditioner, and we're like, oh, it feels amazing. You're feeling the cold air. And then all the power in the house goes out. And so now we're bag mask ventilating her daughter who has congenital heart disease, is on hospice. And I'm like, I am so sorry. I did not mean to kill your baby. That is not why I am here. And luckily we were able to flip the fuse and get it back on. But it's just something to think about, because that's just a small example of what it looks like when you try to care for them at home. And we sit there in our, facility with electricity and all these different things and say, hey, you can do this at home, but what does it look like and what does it feel like? Years ago, I used to teach ethics at in Kansas City at the bioethics at the KCUMB, the DO school there. And one of my technology dependent moms in Kansas, we would do home visits. So I would pack up my 12 masters in ethics students. We would go to her house and we would look at it and just talk to her and see what it feels like. Because those of us practicing in tertiary and quaternary care centers are very judgmental about what we think everybody else can do at home. And I think it's important to have that perspective of how hard it is at home. So acknowledging how hard it is at home, is there ever a time when we as pediatricians should file medical neglect to DCFS for not taking a child home? So you can answer this question in your head, and when we have our 4 minutes for questions, you can let me know what you said. So would you ever report the family for DCFS? We've heard a lot today about structural racism. We've heard a lot about implicit bias. Do you think there's bias in DCFS reports? 100%. Lainey's shaking her head. Yes. So we know, and this is something I had the privilege of working with Cindy Christensen many, many years ago, and Tina Duhame, and this was from 2002. So 20 years ago, they published a paper in the racial differences and the evaluation of pediatric fractures for physical abuse. And based on this paper, the Children's Hospital of Philadelphia put a process in place that any child who had a subdural hemorrhage under 24 months of age would get, be reported to DCFS, get a child abuse consult, because they put a protocol in place, because what they found was that children who were African-American were much more likely to get referred to DCFS, even if it was the exact same injury. So this is a more recent study, if I can find it on there, 2018. And this looks at racial and ethnic disparities and bias and evaluation in the reporting of abusive head trauma. So they said it's been 15 years. Have anything gotten better? And it's really interesting what they found is they said, well, in 16 of the 18 hospitals, it got a lot better. In 2 of the 18, it didn't at all. But that just means, well, they just must be racist. And well, that's okay then, right? And so they really negated their findings by saying that, well, it was just 2% of the time, and well, maybe it was okay. And that's not okay, right? Like they should have written many editorials saying this is wrong. And why aren't we picketing outside of those 2 out of the 18 hospitals that are completely racist in their approach to this? So what do we know? We know that children who are African-American have double the rates of reported child abuse compared to white children. We know that bias does cause overrepresentation, and we really need to make sure that we have really clear policies and procedures in place and that we're not using our bias to sort of justify who we're referring and who we're not. This was data from the University of the state of Washington, so Washington State, and children who were African-American were more likely to be in foster care than in home services compared to white children with the exact same challenges and the exact same injuries. We know that this is the second one is the data from Washington State, that African-American children were 22 times more likely and Native American children were 29 more times to be placed outside of the home compared to white children. So this shows you that there's still ongoing racism in the way we approach children who have concerns of medical neglect. So the government is trying to do this. So they published this in April of 2021, which is a child welfare practice to address racial disproportionality and disparity. So this is more data to show that we still have the wrong kind of representation. So children who are American Indian, Alaska Native, African American are vastly overrepresented in terms of who is in foster care. So African American children are 14% of the population, but they're 23% of the foster care population. What the government report found was that racial disparities occur at every single spot along the continuum based on when you pick up the phone to what happens next. And we know that they're overrepresented and that people are not being treated equally throughout the process. So this, I bring up this example because this is a child from Colorado. Her name is Olivia Gant. She was a child who had some weird feeding intolerance, who knows what. And she had a feeding tube, then she was on TPN. And then her family says, I don't, this life is not worth living. I'm going to withdraw support. They put her on hospice. They have a variety of heated arguments about this at Children's Hospital of Colorado, but they don't ever report her to DCFS. They put her to hospice. I pray every day for peace for the hospice doctor who signed off on all of these things. The mother essentially murdered her. She has since pled guilty to murder. And I don't know what is a more telling example of white privilege, then this lady was allowed to murder her daughter. And people are like, oh, that's okay. You must be right. And they never once reported her. So that is obviously quite problematic. So DCFS and discharge, always ask yourself, what is your role of bias? What judgments do you have? What preconceived notions do you have? And then come up with some mutually agreed upon criteria for discharge that are realistic and achievable. And then we want to give families choices for both transitional care and long-term care. And we really want to avoid using DCFS as a hammer. And I'm going to skip the rest of my talk. So we get to see now, I'm just already going to go ahead and tell you what I'll talk about next year. Thanks. We'll turn my timer off. Questions? I don't know how to turn my timer off. Yeah.
That was awesome. Thank you so much for that.
Thank you.
What changed that we decreased nursing hours?
I can't hear you.
Sarah, what changed? Can you hear me now?
Yeah.
That we decreased nursing hours and decreased support? Because I can tell you, as somebody who works in the PICU discharging these patients, and who was that, Laura Bita? It is so nerve-wracking trying to put together these discharges, and the expectations that we have for these families are so unbelievable. And what these families do at home is incredible. I have nothing but, reverence for my medical mamas and my medical dads and stuff. But what changed that we essentially diminished the support, and we don't give them enough support, especially for, trached vent dependent kids. Parents have to be up all night with them when they don't have nurses.
Right. So for people, Carolyn Skolnick was asking about what changed. Why did we 20 years ago send everybody home with 24 hours of nursing for 14 days as the bare minimum? And why are we now happy if they get 36 hours in 1 week? And I wish I had the answer. Legislatively, nothing has changed. So the same number of hours are paid for. So there haven't been changes in the Medicaid reimbursement model. It's really a matter of staffing shortages, which I think were getting greater over time and then really exploded in the pandemic. And I agree with you, Carolyn, people who care for these children at home, it is extraordinary. And if my child was like that, I'm not sure I would want to take him home. When I talked about this at Loyola, I shared that my son had been admitted to the hospital for suicide. And when told me to take him home, I was like, I don't think so. And then everyone at Laura Bita joked with me, and they're like, they're going to call DCFS on you. I'm like, I know they will. But you think about, that's a tiny little thing. And we ask parents to do a lot. Sorry, I'm so emotive. That hasn't changed. I still cry on demand. Yeah. Right. It's a great question. She was asking about support for home, and there's not. When we think about housing support in the city of Chicago, it's non-existent. So we have one of our patients that super, super well has been ready to go home since July. It's now November. And the reason he has not gone home is because the manager of his Section 8 housing has not approved the electricity upgrade. And he cannot go home until the electricity upgrade happens. And his mom and his aunts and everybody have learned his care. He's been ready to go since July. And we advocate for them, and we send, DSCC workers to speak to the manager, and he's still waiting. So there's not anything. And I think we talk a lot about food insecurity, but there's also a huge issue with housing insecurity. And for us as healthcare providers, I don't have anything to offer them. Here's the number for the Section 8 housing. We don't do anything else. I mean, I think in the ideal world, we would build like they have in California, the George Mark House, where they have a hospice house, but do like a big house where everybody can live together and have different apartments and, really create the village. It's sort of what Peter Smith did at Almost Home, but create something like that for families that's as tall as Lurie, because there's enough kids that need it. But for housing, we don't have anything. Right. 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 Yep. Okay. Thank you.
Our final speaker in this panel is Rick Kodish. Rick will be talking about finding the balance, hope, and honesty in refractory childhood cancer. Rick is a pediatric hematologist and professor of pediatrics at the Lerner College of Medicine of Case Western Reserve University. He's vice chair for professional staff affairs and faculty development in the Pediatric Institute. He also co-directs the Art and Practice of Medicine course in the Lerner College of Medicine Years 1 and 2 curriculum, and chairs the APM steering committee. He has joint positions, appointments as professor of bioethics and oncology at Case Western and in the Cleveland Clinic Center for Bioethics. And he did serve while there for over a decade as the chair of the ethics department. Welcome, Rick.
Thank you, Lainey. Thank you, everybody. So good to be back together in person. And I know that there's 100 people on Zoom, so welcome to you and thanks for listening. And hopefully we can all be together in person before too long. I want to talk about finding the balance. And we've had some emotional moments, and I guess, going to stick with that theme. This could be a bit of an emotional talk. Consulting agreement that is not relevant. I want to talk about the tension between fostering hope and providing prognostic honesty when we're working with children and families who have been overmastered by disease. I want to think with you about narrative competency and the potential of narrative to help cope with the face of tragedy. And specifically, this is sort of dedicated to my colleagues who take care of kids with cancer and the challenges that they face and the potential for self-care that I think narrative holds for them. Pediatric oncologists have a hard job. When I was doing it, which was about the first 20 years of my career, I would find myself at a cocktail party. Someone would say, "What do you do for a living?" And I would say, "I'm a pediatrician." And that allowed me to be honest, but to not watch their jaw drop. How do you do that? Oh my God, that's so terrible. It's a hard job, even though most childhood cancer is curable. But when it is refractory, things get very complicated. Children and their families want hope and they want honesty, generally speaking. And this results in a dilemma. And this is a slide I think I've shown at this conference before. It's my favorite definition of a dilemma, a situation where there is no right answer, conflict between right and right, or between wrong and wrong. Whatever we do, we're doing something that in other circumstances we ought not do. A good ethics word. What ought we do? In such a conflict, there could be a proper way to act, but it doesn't cancel out the emotional pain. And that's from the late Rabbi Jonathan Sachs. So, right and right. It's right, I think, to provide reasonable or at least reframed hope. And it is right to be honest about prognosis and life expectancy when children are overmastered by cancer. It's also wrong, I think we would agree, to promote false hope. And it's wrong to insist on brutal honesty that would extinguish all hope in the course of prognostic disclosure and discussions about next steps. From my years of grant writing, I learned about anticipated critiques, and I want to just put that up here. Some people may say, well, Rick, this is a false dichotomy. There's got to be a middle path, and you're just being hyperbolic. It's not that extreme. And I will tell you that we've walked down this path. It's not a false dichotomy. It's very real. There's a tension that we articulate in a paper that's now under review. And the day-to-day lived experiences of families and children and pediatric oncologists, I think, tells us that this isn't just a false dichotomy. Hippocrates, in this, I think, beautiful quote said, "First, I will define what I conceive medicine to be. In general terms, it is to do away with the sufferings of the sick, to lessen the violence of their diseases, and to refuse to treat those who are overmastered by their disease, realizing that in such cases, medicine is powerless. And as we move into 2023, it's important to remember that sometimes medicine is still powerless." So a little bit of ethical guidance before we move into narrative here. Always listen first and listen carefully. We talked about pediatric ethics earlier. Really important that we do not conflate the child patient with his or her parents. In these situations, especially, they are unlikely to be completely aligned, certainly when you have an older child. And you have to remember that mutual pretense is, if not ubiquitous, extremely common in this situation. And for those of you not familiar with that term, one way to think about mutual pretense is it is the desire of individuals within a family unit to protect one another from painful truth. And we see this as an older child wants to protect his or her parents from the pain, and when the parents want to protect the child. So that makes it tricky. I also want to stipulate that the lack of curative option does not mean the treatment is futile. And treatment in the form of a clinical trial adds complexity and I think brings value. And we'll go forward here with a little more ethical guidance about clinical trials in this situation and the difficulty of having those discussions when children are overmastered by disease. And here I'm talking about the phase 1 trial context. There are different kinds of hope, I think, that can be relevant in these discussions. One is hope for a tumor response. That's sort of the scientific hope in many ways, although there is a scientific goal of finding the right dose of a medication also. There's the hope of finding meaning in tragedy, that is of altruism. And then there's the value of doing something, which I think is often debated, you know, let's just do something. We need to do something. And I think families and children do find that valuable, and it would be kind of dismissive of us to not consider that. At the same time, investigational approaches are not innocuous, and there's a high risk for therapeutic misconception. Hopefully most of you know what TM is. I'm not going to have time to define it, but really important concept in research ethics. So what about narrative? In this really, I think, seminal paper from 2001, there's a discussion of 4 domains that narrative can be helpful. One is in the patient-physician discussion in that conversation, informed consent, the dialogue about what to do. Ed Pellegrino said, I think, what is wrong, what can be done, and what should be done. And that's the conversation talking about there in the patient-physician domain. The second is the physician self, which I'll comment on a little bit later. Physicians with one's colleagues. And then one domain I'm not going to touch on in this talk is physicians and society, but narrative has a role in each of these 4 domains. And I encourage you to take a look at this paper, 20 years old now. I am going to talk about a case. I'm going to say that there's a new drug called narrativimab. Narrativimab targets a molecular transformation in cancer cells, and it's being studied in children who have terminal cancer. And I am a pediatric oncologist. Let's just say I've been taking care of a 12-year-old, mature 12-year-old who can make many of her own decisions, named Abby. I've been her doctor for 18 months. She's dying. She has widespread metastatic disease in her lungs and multiple bones. She is eligible for the narrativimab study, but it holds only a remote prospect of helping her. At the same time, it could be risky and it could accelerate her death. Without participation of children like Abby, knowledge about the drug and others like it will never be obtained, and we won't discover better treatments for kids with cancer. She looks at me and says, do I think she should be in the study? So how do I answer this question? How do you answer this question? How do you think about the moral issues? How do you think about the emotional components? Do you owe it to future children to encourage her to be in the study? Do you let your parental protective instinct come out and say, no, I don't think you should be in this study. It's unlikely to help you. It may increase your suffering. Should I dodge the question? Many doctors who are human will dodge the question and say, there's no right or wrong decision. Or do you owe her a more substantive answer? So I think how do we interpret the story of her asking that question is fundamentally sort of a narrative question. Is she looking to me for hope? Is she seeking permission as her doctor to stop fighting? And I don't know how to best respond, but I wanted to sketch out for you 4 possible endings of the story. Ending 1A is that Abby enrolls in the narrativimab study and she suffers a toxic death. Ending 1B is that she enrolls in the study, she has some tumor response, and she experiences meaningful altruism. Ending 2A is that she declines the study, enrolls in hospice, and has a peaceful death with her family at the bedside. And scenario 2B is that she declines the study and she dies painfully and with decisional regret about not participating in the study. There are many, 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 many more endings one could imagine, but these are like 4 basic ones that I thought it would be interesting to put out there. And allow me to get back to narrative analysis a little bit. So there's surface narrative, and what I just showed you in the previous slide very much is surface narrative. And then there's a deeper counter narrative. There are thick cases, thick details we can talk about. Those who study narrative analysis talk about plot being important, characters, Abby, the doctor, or the 2 characters in that case, voice, who the narrative voice belongs to, the setting, is this taking place in the hospital, in the clinic, the theme or themes, conflict, and style. These are just some of the components of narrative analysis I'd like you to think about. And I would suggest that there's a magic to narrative. The idea that I've been thinking about recently is what I'll call interpretive latitude. When I hear a story, I'm going to hear it differently than when Peter hears a story or when Marshall hears a story. We bring something to that narrative as we listen to it, and that interpretive latitude, I think, allows us to find meaning and get through some of the tragedy of cases like this. I think it can help us to balance hope and honesty. If it's utterly tragic, we can tell the story in a more hopeful way. If it's overly hopeful, we can bring it to reality a bit. I think it does allow us to engage with patients in a relationship-centered way, that is, to tell stories to our patients, and more importantly, to listen to our patients and their family stories. I think it can provide solidarity and support, as I said before, to one another, pediatric oncologists, ICU doctors, you name it, the people that are suffering from moral distress. And Lord knows, after the past 3 years, there's a whole generation of PTSD scarred doctors and nurses. And I think it can catalyze reflective practice. And this is this issue about physician and self. The medical school that I'm privileged to teach at has a very strong emphasis on reflective practice. And I think narrative is part of that excellence in reflective practice. I'm going to wrap up with a final question. I think about the late Dr. Oliver Sacks, who was the master of talking about a case. And I think about stories, and I want you to think about similarities and differences between cases and stories. I always tell my students that good doctors are good readers, that it's a requirement to have read When Breath Becomes Air, let's say, or to have read Rushdie. To be a good reader, I think really helps one to be a good doctor. I'm not sure I'm ready to say you can't be a good doctor unless you're a good reader, but you could be a much better doctor if you're a good reader. We talked a little bit earlier about AI, machine learning, and decision support. And as those become the new evidence-based medicine, I think the power of narrative is at a bit of risk. And I guess that's my plug in this talk, is to keep narrative in mind, to counterbalance that. And I think storytelling can help balance hope and honesty in refractory childhood cancer. The Nobel laureate Isaac Bashevis Singer, who's sort of blocking the slide there, said, when the day is done, I think, it is no longer there. What remains? Nothing more than a story. If stories weren't told or books weren't written, man would live like the beasts, only for a day. The whole world, all human life, is one long story. And I'd like to thank my colleagues, and happy to take questions if we have time. Also happy to have lunch. We have time, lady? Yeah, thank you. Marshall.
Great talk, Rick. So I also love personal storytelling and all. Because of the time, you didn't have a chance to go into more depth about, but we had a couple pieces last at the end about format for storytelling, and then the difference between superficial and deep stories. Can you apply that to like the example you gave, and especially of like if you're counseling a child and family, regarding options and whatnot, a little bit more about how you would apply those powerful ideas to cases of the story.
Yeah, thank you for that. I would say that with a family relationship and continuous meeting over time is really, really important, because I think what you get first is the surface narrative. My child's a fighter. I want him to keep fighting. I can't imagine life without him. And then as they unfortunately experience the suffering of that child, the symptom burden, sometimes I think their own counter narrative emerges to see potentially that, we could shift the goals of treatment. Or it could also, go the other way as they understand what a phase 1 trial is and the needs of other children with cancer. And I've seen remarkably altruistic parents and kids who, after their kids die, they start a foundation, and for decades and decades, they're committed to fighting childhood cancer. So again, I think understanding that the surface narrative is tempting to just sort of jump on that and go with it, but to be patient enough to listen deeper. Yeah.
A wonderful talk. Thanks so much. I was wondering about I guess kind of like the fallibility of memory and kind of ourselves as protagonists in our own story, and the idea that having narrative after a death, we always think, or I always think about eulogies and kind of the celebration of life, but also that you kind of think about only the most positive aspects of an experience somewhat, to kind of make sure as a clinician that you're not kind of mired in all of the negativity that comes in our everyday experiences, treating death and kind of experiencing death over and over, and just how narrative works with that in terms of the tension between honesty and self-reflection.
Yeah, thank you. I don't think accuracy is the goal of narrative, I guess, is sort of the brief answer. I think meaning making and being able to sort of continue on is the goal of narrative. And it's interesting to sort of think about the goals of medicine, objectivity, evidence, and narrative. And I guess you could say that maybe they're not so aligned, but as I think about it, it's hard to imagine me being interested in being a doctor if there wasn't narrative and storytelling. And I think our patients usually, I think the whole anti-vaccine movement, really, we've failed terribly at not being able to tell a story about it. We're using numbers, the scientific establishment, and it's a good example where if we had taken a different turn, I think we would be doing better with vaccination. Okay, thank you.
So thanks everyone for the morning session. We will be resuming at 1:30. So we have 1 hour to have lunch. Thank you all for coming. And for the Zoomers, we'll be back in 57 minutes.